This lecture will wrap up Chapter 49, The Child with Alteration in Tissue Integrity. We're going to start with skin infections. Of this list, we're going to focus on impetigo, candidiasis, tinea infections, and also we're going to hit on frostbite and pediculosis. So we're first going to start off just talking about skin infections in general. So skin infections are common in childhood. Bacteria are normally present on healthy skin. Hopefully you already know that. And then the risk for infection depends on different factors for the child. So the skin's susceptibility to bacterial infection depends on several factors, including intactness of skin. So if there's an opening or if they've scratched open an area of their skin, the virulence of the organism, so how strong it is to sort of cause that infection, and then the child's immune status. Children are susceptible to fungal and viral infections as well. Unlike bacterial infections, which generally respond fairly quickly to treatment, fungal and viral infections can be persistent and challenging to treat. In terms of bacterial infections of the skin, Staphylococcus infections are the most common bacterial infections of the skin that we see. So the first one we're going to talk about is impetigo or impetigo. You can hear it pronounced both ways. This often occurs as a secondary infection from another skin lesion, such as an insect bite. Close contact contributes to the spread of impetigo, which is highly contagious. If a child is at daycare, school, or camps, they're going to be at increased risk because of the increased risk of coming into contact with other children who might be infected. The incubation period for impetigo is 7 to 10 days, and it can spread to other parts of the child's skin or to others who touch the child using the same towel or drink from the same glass. Spread of infection is fostered by poor hygiene, crowded living conditions, and a hot, humid environment. Lesions resolve in 12 to 14 days with treatment. Under etiology, impetigo is caused by Staphylococcus aureus. Pathophysiology. Impetigo begins in an area of broken skin, such as an insect bite, scabies, or atopic dermatitis. The break in the skin allows for the organism, the Staphylococcus aureus, to enter. Inflammatory process results in the formation of a pustular lesion. Honey-colored fluid from the lesion becomes crusted in some children. Nasal discharge containing the organism erodes healthy skin above the upper lip, allowing the organism to enter. Under incidence, most common during hot, humid summer months. Under manifestations, the primary lesions of impetigo occur in two forms. You have the bullous impetigo, which manifests as small vesicles that can progress to bullae. Bullae are lesions that are initially filled with serous fluid and later become pustular. And here's a visual for you of what bullae look like. The bullae rapidly rupture, leaving a shiny, lacquered-appearing lesion surrounded by a scaly rim. Crusted impetigo appears as a vesicle or pustule that ruptures to become erosion with an overlaying of honey-colored crust, and that's what you see on this slide here. Scarring is uncommon, but can occur if the child picks or scratches at the lesion. Post-inflammatory hyperpigmentation is a frequent sequela, so we see it after the infection, in dark-skinned children. Lesions are often located around the mouth and nose, but can appear on any part of the body. For diagnosis, the characteristic appearance of the lesion usually confirms the diagnosis. If the lesion does not respond to treatment, a culture would be obtained to see if the patient has MRSA. Under therapeutic management, impetigo is treated with topical and oral antibiotics. Again, think about what's causing it. It's a Staphylococcus aureus, a bacteria that's causing the infection. Lesions should be gently washed 3 times a day with warm, soapy washcloth and the crust soaked and carefully removed. A topical antibiotic is then applied to the lesions. Topical treatment lasts 7 to 10 days. Severe cases of impetigo or cases around the mouth are treated with oral antibiotics that are effective against both staph and strep. Impetigo that is extensive is treated with IV antibiotics. Good hand washing and careful hygiene are imperative to prevent the spread of the infection and should be emphasized to the child and caregivers. The child should not attend school or daycare for 24 hours after beginning treatment. There's a purple nursing process box for care of the child with impetigo on 1179. And I want you to look over that on your own and pay particular attention to interventions. You also have a yellow box about care of the child with impetigo, and it just talks about how it can be spread easily and the concern with scratching, opening up areas of the skin where the Staphylococcus aureus can then infect again. It advises that we tell caregivers to keep the child's fingernails short and encourage the child to wash their hands frequently with antibacterial soap. We want to also discourage family members from sharing towels, combs, or eating utensils with the infected child. The next condition we're going to talk about is candidiasis, specifically oral candidiasis, also known as thrush. It's a superficial fungal infection of the oral mucous membranes that is common in infants. It is caused by overgrowth of the fungus Candida albicans. It can occur, the infant can contract it when passing through an infected vagina at birth. An older infant can experience it if they're get infected with it if they are immunocompromised or have experienced immunosuppression. They're receiving antibiotic therapy. They can get exposure from a mother's infected breast or from unclean bottles or pacifiers. Usually occurs most often in infants. A predisposing factor in all age groups include antibiotic therapy, infection with, not infection, but with that if the patient has diabetes or any other altered immune status. Manifestations include white curd-like plaques that are noted on the tongue, gums, and buccal mucosa in children with thrush. They can be distinguished from milk curds by the difficulty encountered in removing them and the bleeding and the red base when the plaques are removed. So if they're removed and then you see a red base that can bleed, and it's not just milk curds that have formed because of feedings, we're looking at a fungal infection, Candida albicans. A child with a severe infection may have difficulty eating. Therapeutic management for oral candidiasis includes nystatin oral suspension swabbed onto the mucous membranes of the mouth. You might have used nystatin in the clinical setting with adult patients. Sometimes patients who have skin folds can get fungal infections in those skin folds, so there's a nystatin powder. In this case, again, we're talking about an oral infection, so we're using an oral suspension. There is a purple nursing care box for the child with candidiasis on 1181. Under interventions, I'm going to let you look over it on your own, but I want to stress under interventions, it says teach the parent to swab 1 ml of oral nystatin suspension onto the infant's gums, tongue, or buccal mucosa every 6 hours until 3 to 4 days after symptoms have disappeared. Because cotton-tipped applicators tend to absorb the medication, it's more effective for the caregiver to rub the suspension on the mucous membranes with a gloved finger. To increase the amount of time that the medication is in contact with the mucous membranes, nystatin should be applied after feedings. Pacifiers, nipples, and bottles should be thoroughly cleaned to decrease the chance of reinfection. Teach the parent the technique and importance of good hand hygiene. If the infant is breastfed, the mother's breast should also be treated with nystatin. I'll let you look at the rest of those on your own there. Here's a picture of diaper candidiasis. Again, when you see candidiasis, you should think fungal infection. So a diaper candidiasis infection is treated with a topical antifungal agent like nystatin. With thrush, we talked about it being used orally. It can be used topically also. Also, if you see any medications that end in azole, azoles, that should be a clue to you that you're dealing with an antifungal medication. Next, we're going to talk about tinea infections. Tinea is a superficial skin infection caused by a group of fungi known as dermatophytes. Tinea infections are designated by the word tinea followed by the Latin word of the affected body part. If you look at 1181 under pathophysiology, you have a box that talks about the different locations for these fungal infections. Tinea capitis In Tinea capitis, the fungus invades the hair shaft, causing the hairs to become brittle and break off at the level of the scalp, leaving an area of stubby black dotted alopecia. Tinea corporis is also known as ringworm. It's a fungal infection of the face, trunk, or extremities. It can be transmitted by humans or by dogs or cats. Most lesions of Tinea corporis clear without treatment in several months, but some may become chronic. Tinea cruris is also known as jock itch. It's characterized by an intense inflammatory reaction with severe pruritus. And finally, tinea pedis is also known as athlete's foot. It can become chronic, particularly in adolescents who wear unventilated athletic shoes. Can have secondary infections with bacteria or candida. In terms of therapeutic management for these fungal infections, the fungus likes moist, hot environment. So tip number 1 is to keep the infected area as dry as possible. Don't share personal items, towels, washcloths, combs, hat, or hair ornaments. Want to make sure we're washing the area daily. Again, keeping dry. For treatment for tinea infection, obviously the cause is fungal, so the treatment is an antifungal. And a lot of times those medications, again, end in azole. So at this point, I just want you to recognize if you see the medication that's ending in azole, you should be thinking it's an antifungal. It's one that might be used to treat tinea infections. For topical treatments, it's usually a twice-a-day application, and the application of the topical ointment or cream should extend 1 inch beyond the lesion's borders. Let's see. On page 1183, you have a nursing care of the child infected with tinea infections, and I want you to go ahead and look over that on your own, as well as the patient-centered teaching box on 1183 about how to care for the child or adolescents with a tinea infection. We're going to wrap up this recorded lecture with frostbite. So frostbite is the freezing of tissue resulting from exposure to extreme cold. This is on page 1192. Exposed areas such as fingers, toes, noses, cheeks, and ears are most often affected. The cold causes arteriolar vasoconstriction, which results in tissue anoxia and destruction. In terms of the manifestations that are presented on table 49.1, just look them over and understand sort of how they progress. So early signs would be blanching of the skin, stinging, followed by numbness and white mottled appearance. Areas feel cold, hard, and maybe without sensation. And it can progress to a 4th degree, which is complete necrosis with gangrene, possible loss of a body part. In terms of what we should be teaching the children, we want children in cold climates to be taught to prevent frostbite by wearing adequate layered clothing, hats, gloves, 2 pairs of socks, 1 cotton, 1 wool. Children should be taught to warm themselves when hands or feet begin to sting. So they need to be taught that when they're experiencing that, it's time to go inside and warm up a little bit. Young children should not be allowed to play outside in extremely cold temperatures. Now, we haven't talked about pediculosis yet because it's going to be a separate recording unless you watch that first. But we'll do this question because we have it pulled up. The nurse is talking to parents of a child with pediculosis capitis. When explaining how to manage, the nurse should state what? You can pause this and look it over. If you answer D, you will need to remove nits with a fine-tooth comb or tweezers. That is the correct answer.